Hello, and welcome to the DECERA Clinical Education Aligning Early Advanced IBD Therapy with Patient Priorities podcast. I'm your host, Joshua Schechtel. Today's episode features Doctors Jessica Allegretti, Jordan Axelrad, Russell Cohen, and nurse practitioner Amy Stewart. They will be discussing new therapies for patients with inflammatory bowel disease. This episode is part of a larger educational program titled Survey Says, Aligning Early Advanced IBD Therapy with Patient Priorities. For more information on our faculty, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
So it looks like I have a question here for Jessica. So it says, Jessica, what would you do in the situation of a patient with Crohn's disease who is going to be initiating a biological or advanced therapy, moderate severe Crohn's disease, but she also recently got married and is planning to start a family? How would that impact your decisions on treatments?
Yeah, so we know that with regards to our therapeutic landscape, the biologics, which are monoclonal antibodies, are safe in pregnancy and can be used. The small molecules, which include the JAK inhibitors and the S1P receptor modulators, should not be used in pregnancy or in patients who are imminently going to get pregnant. That being said, I would have a conversation with her about what her timeline is, what her family planning status is. If I really thought that one of the small molecules was the best option for her and I needed to get her into remission, I wouldn't withhold that therapy just because she is a woman of childbearing potential. But if she says to me, the second you get me better and the second I feel better, I want to start trying to have children, then I absolutely would take that into consideration, because then you would have to, potentially switch therapies. And so these are conversations that I have early and often with my patients. And I also counsel my patients early, even before they're thinking about having children, to remind them, don't stop your therapies, talk to me. We want to assess you before you start trying to get pregnant to confirm that you're in remission, because we know that patients who get pregnant in remission are more likely to stay in remission and do better. So big picture, our biologics are safe. They can be continued in pregnancy and should be, and patients can breastfeed on these therapies. The small molecules, though, can be stopped basically right up until they want to start trying. Both of them need about a week washout, and then patients can start trying to conceive if that is what they want to do.
And is there still a recommendation that the babies born to mothers who are on biologics, or small molecules, biologics, avoid the rotavirus vaccine?
Not anymore. So there's now data that these babies do fine. And so there is no need to withhold the rotavirus vaccine, which happens in the first 6 months of life, which is an oral live vaccine. It's the only live vaccine that babies get within that first year. And so to our moms on any of our therapies—
In the United States.
In the United States, excuse me. There's no need to withhold that, so you don't have to counsel your patients on that anymore.
But you do not give the BCG vaccine if you're to these babies.
Yes, if you're outside of the U.S.
Okay, bad things can happen. So Jordan, we have a question here. A patient I saw recently has left-sided ulcerative colitis, pretty inflamed. I did a colonoscopy, and he was on mesalamine. And the pathologist, one of the biopsies came back indefinite for dysplasia. Should I be sending this patient to surgery? What should I do?
Yeah, that's a good question. I think a couple of things. One is, was this a lesion or was it just a random biopsy, right? So if it's a random biopsy, now that patient needs to come back for an exam using image enhancement for a colonoscopy with either virtual or dye spray chromoendoscopy, perhaps preferably dye, depending on the study you look at, or sent to a gastroenterologist with experience doing that. If it's a polyp that you completely removed that had indefinite, that's great. Now you have to ask yourself, is the patient's disease activity being adequately controlled? So is the reason there was indefinite for dysplasia because disease was very active, or was disease totally quiescent? That'll impact your next treatment moves as far as therapies are concerned.
This patient is only on mesalamine, so you would optimize their therapy with effective for moderate severe ulcerative colitis and bring them back in 6 months, maybe rebiopsy them using narrowband imaging or chromoendoscopy.
Yep.
Right? That's
exactly.
Yep. Okay. Jessica, my patient here has been on an anti-TNF therapy, but now they're getting psoriasis on their scalp, behind their ears, and the umbilicus. The dermatologist has suggested that I just lower the dose of the anti-TNFs? What's the options?
Yeah, so this certainly does happen, this sort of paradoxical psoriasis that happens with anti-TNF therapy, even though anti-TNF therapy is also a treatment for psoriasis. So this paradoxical relationship can happen. I work very closely with my dermatologist. Depending on how severe the psoriasis is, we often try to manage with topicals if we can, especially if the patient's doing very well on their anti-TNF therapy. If, however, the psoriasis is really becoming a quality of life issue and really quite bothersome, which certainly can happen, the great news is that we have therapies that will treat both, and so this is a great opportunity to move to an IL-23. Any of them would be appropriate. They all work for psoriasis as well, and so working closely with my dermatology colleagues, we'll sort of discuss which one we think is best depending on what's going on with the patient. But this may be an opportunity to switch to an IL-23, and then you can manage both issues concurrently.
Okay. Switch and manage them. Yeah. Especially if
unfortunately, usually these patients, their IBD is quiescent, when this happens. If their IBD isn't, then, you even easier to switch. It's sort of sometimes heartbreaking when you have to leave a drug that they're doing well on otherwise.
Yeah. Okay. So, Jordan, patient is on an anti-TNF and has developed suggestions of possible demyelinating condition. They called a neurologist who said that they don't have MS. They're coming due for their next infliximab infusion. What should I do?
Yeah, so this is a rare complication that can occur in patients on anti-TNF agents or sorts of demyelinating conditions that could be MS-like. So that would make using an anti-TNF relatively contraindicated. So you would definitely have to move away from that as an option and use another therapy. So I think for that's an easy one, but quite rare. And usually I'm leaning on my neurology specialists to tell me whether that's actually the case, right? So patients may have symptoms that they think is MS, and of course a new diagnosis of MS needs to be differentiated from a complication that is demyelination related to anti-TNF therapy. So you definitely need neurology colleagues to help you with that.
Okay, so you don't go back to a TNF, and luckily we have more options now.
Yes.
Yep.
Okay, so here's a question for Jessica. So Jessica, I have my patient with Crohn's is on adalimumab, and whenever I check anti-drug antibodies and drug levels, the drug levels are good, but they have some anti-drug antibodies. Should I switch therapy? They're doing well.
So no, right? So I think, again, the key point here is that you can have antibodies that are neutralizing and non-neutralizing. Our assays are much more sensitive these days, so often we'll pick up these low levels of antibodies. So I think the key point here is the patient is doing well and they have drug level. So where to be concerned is when you have no drug level and high antibody titers, because that means you're essentially negating drug. You're not getting any benefit from that drug, and that would be time to move on, even if the patient was doing well, right? Because it's sort of inevitable that they're going to have a collapse at some point. But if the patient does have adequate drug levels, or even if they've got low drug levels, that's maybe an opportunity to optimize and try to overcome those low-level antibodies. I would probably get a fecal calprotectin at that point too, just to confirm that the patient is actually doing well, even if they're saying that they're clinically fine, just to confirm that. But if the patient does have an adequate level, even with low-level antibodies, I'm not abandoning that drug in that moment.
Okay. Jordan, anything to add to that? Or?
No, I agree with that completely. I mean, I think we didn't discuss, but as far as drug level checking, when you should do it, when you shouldn't do it, that's also an open topic. So, my typical approach is that for sick patients, I'll proactively monitor the anti-TNF drug level, infliximab obviously primarily. For not so sick patients that I'm starting infliximab, I'm actually not proactively monitoring the level. But of course, for anyone like just described that's not doing well, that's suddenly having refractory symptoms, there you definitely want to get the drug level and antibody titer.
In patients with moderate to severe ulcerative colitis or Crohn's disease, how do you sequence advanced therapies, and which factors most strongly drive your first choice of first-line biologic or small molecule? So I think the best answer here is really thinking about getting our patients on therapy, right? Getting our patients on a therapy that works and getting them on a therapy that works quickly. So how can we do this? So any advanced therapy is a good option over no advanced therapy. But thinking about the guidelines in patients who are naive, for example, in the AGA guidelines, we have this class of higher efficacy medications for those who are naive. And again, they're not listed in order, so which one do I pick? We really go through the shared decision-making model with a patient. First, I think about how sick are they? Do I need something that's going to work very quickly, or do I have a little bit more time? If I need something that's going to work very quickly, then I need a medication that works very quickly. So in patients who are very sick, who I need something very quickly, first line, I might be thinking infliximab, particularly if they're on the borderline of going into the hospital. But if I've got more time, then really the doors are open to me and I can choose any of those therapies that are positioned there for higher efficacy for naive patients. So then I talk about options to the patients. I talk about, could you get to our infusion center? Do you have an infusion center in your practice that your patient could get to, that you can get drug to, and also quickly? I'm very lucky that in my practice we have an infusion center that I can get therapy pretty quickly. Our average prior auth was 3 days, and I can get new drugs start within about 14 days, but that's not the case for everywhere. And so if it's going to be 2 months before you can get an IV, you might think about another option for that patient. Then I also talk to the patient about continuing therapy. So, okay, if we do IV induction, can you continue coming to the infusion center? Or do we need to think about something that has a sub-Q option? In my practice in DC, many of my patients are young. They travel a lot. They work for the State Department. They're on the Hill. They're all over the place. So thinking about them as people, thinking about social determinants of health. Do they have a refrigerator? Can they store their medication at home? Can they get packages if it's delivered to them? I've had patients who've had their drugs stolen from porch pirates. So really thinking about all of these things, but also following the guidelines in terms of shifting me into certain medications or certain classes that are higher efficacy. Another question that came up here is, are there particular patients who would not be considered candidates for subcutaneous maintenance infliximab or vedolizumab for their IBD? And that's a great question. In the clinical trial, sub-Q for both infliximab and vedolizumab were as efficacious as IV, but we also need to think about what dose they're currently on. So if it is a patient who is already on therapy, remember that vedolizumab was compared every 8-week dosing of IV versus every other week sub-Q. So if I have a patient that's on vedolizumab every 4 weeks, I might be weary about transitioning them to sub-Q because they already need dose escalation, and that's very hard to do sub-Q with an every other week pen. Similarly for infliximab, if I have a patient who's doing well on 5 mg per kg Q8, that is a great patient to think about switching to sub-Q. But in the studies, patients who were on 10 Q4, 10 mg per kg Q4 week dosing, a large number of them lost response within 6 months. Now, 80% of them were able to recapture response when they dose escalated. But again, particularly with insurance, it's really hard to get these sub-Q pens dose escalated. So for patients who are on standard therapy, those are good candidates for subcutaneous maintenance. The other consideration you might think about is, for me, we have our own infusion center. So I can really keep eyes on these patients when they're coming in for infusion and make sure they're getting their therapy, right? If you're worried about someone who's going to kind of set it and forget it and not take their sub-Q, then you might think about that as well. So just thinking about, I don't like to use the word compliance, but how can we keep our patient on therapy appropriately? There's another question here. Will be practicing in internal med primary care? Will I be initiating therapies like this or better refer to GI? So I think it depends a little bit on your demographics, right? If there is no GI care for 6 months, then it's not unreasonable for you to know about these therapies and consider getting your patient on something. But I will say that more realistically, probably these are best handled by GI. And not even all of GI do a lot of IBD. Sometimes even in practices like mine, some of the docs refer their IBD patients to certain physicians just because it's harder to keep up with, quite frankly, when there's so many things and so many therapies. But I think our primary care colleagues can really help with keeping our patients off steroids and also helping to increase access to GI. So if there's a 6-month wait and you've got a patient who you suspect has IBD or is flaring, how can you help get that patient to GI so that we're not in the urgent care cycle and steroids? So how are you incorporating treat to target principles into routine practice, particularly with respect to endoscopic healing, biomarkers, and cross-sectional imaging? So thinking about treat to target principles, right? We've got the short-term goals, which is where we want our patients to feel better. And that depends on what your patient's symptoms are. So in a patient with diarrhea or rectal bleeding, certainly you want those to reduce. But sometimes our small bowel Crohn's disease patients, for example, just feel intermittently bloated. So it's about maybe they have more energy. Maybe those bloating episodes or obstructive episodes are decreasing. In those patients who don't have diarrhea and bleeding, you're not going to see reductions in that, right? So what are their symptoms and how are we monitoring them? After feeling better, then we want our patients to have improvement in their biomarkers. So this, thinking about kind of in that first 3 months of induction therapy, following CRP, and then at 3 months checking a fecal calprotectin. Now, there are some patients who don't mount a CRP or a fecal calprotectin response. So in those patients, if they don't have an elevated CRP or fecal calprotectin when they're flaring, a normal one isn't going to help us. It's not going to tell us anything if it's always normal, right? So thinking about those patients, what are their biomarkers that do correspond with their disease? So some patients, they might get anemic or they might have an elevated platelet count. So understanding at baseline what of your biomarkers tells us that your patient has active disease and how can you follow that over time. So checking those labs in induction, fecal calprotectin at 3 months. And then when you see that start to come down too in the intermediate targets, you move on to longer term targets, which are things like endoscopic healing. So in my practice, we usually repeat a scope about 6 to 12 months, more often 12 months, if they're doing well and their biomarkers are improving. We push it out to the 12-month mark. If you're not sure if there's a response, if the biomarkers are not there or the patient's not feeling well or you're just not sure, then we might do it sooner at 6 months. Remember now that in the guidelines, histology is not yet a recommendation, meaning if you get endoscopic healing, hot diggity dog. I've got a dance that I call the deep remission dance that my patients get when they come back from colonoscopy. But if they feel good, if their biomarkers are normal and endoscopically is normal, but there's a little bit of smoldering inflammation on histology alone, we are not currently changing therapy just on that histology alone. So that's why I use those treat to target principles. Now, if a patient, for example, has small bowel Crohn's disease and really MRE or CT is the best way to evaluate that patient, we're typically repeating that about 6 to 12 months after starting therapy. Our practice just got intestinal ultrasound, and so we are starting to use this at baseline and then also early at 8 to 12 weeks after starting therapy to assess response. There's some data that you can see a response as early as 2 and 4 weeks with the IUS as well. So using that if it's available to you. But I also completely understand that intestinal ultrasound is not widely available. And so if you don't have it, you can't use it. So let's use modes to monitor that we do have, right? So thinking about our calprotectins, CRPs, biomarkers, and then looking at endoscopy and imaging. Another question here, what health maintenance recommendations do you emphasize for patients prior to initiation of advanced therapy and during therapy? And do you have a process of standardizing this in your practice? This is a great question. We use the IBD Cornerstone checklist most frequently is the one that we use in practice. There are several that exist to help keep track of all of health maintenance. So prior to starting therapy, you want to make sure your patient is up to date on all age-appropriate vaccines. If it's a therapy that has a higher risk of shingles, we like them to get their first dose of vaccines before starting that therapy. But also remember that if your patient is on steroids, they're not going to mount a great response to the vaccine. And so if your patient is on steroids, we wait until they're under prednisone 20 milligrams in order to vaccinate. Otherwise, it might be kind of a wasted vaccine, right? They're not going to mount that response to it. With our biologics and advanced therapies, there are no live vaccines while on these advanced therapy. So if your patient needs a live vaccine, they shouldn't really unless they're traveling. But for many of them, you need to do the live vaccine and the second one. If there's a second one, for example, like chickenpox, then you need to wait 4 weeks before starting your advanced therapy. So no live vaccines while on therapy, but otherwise, we often don't hold therapy while we're waiting for vaccines. So we often get things going, right? The most important thing is to get patients off steroids and on a therapy that works for them. You can do vaccines while they're on their advanced therapy as long as they are not live. So thinking about that. And then also it can be really overwhelming when starting a new therapy. So in our practice, we have an NP or PA who sees all of our patients during their IV induction doses, so at each IV. And we talk about all things health maintenance at the second infusion. Because the first one, it's overwhelming. We're talking about safety and answering questions, infusion reactions, etc. So it's at that second infusion is when we do it in our practice. We also give the patient the IBD cornerstone checklist. We circle what they need to get, thinking about dermatology, colon cancer screening, pap smears, etc. And then we also follow it. So we check in at least annually on all things health maintenance. We try to do it 6 months when we can, but at least annually, making sure they are up to date on things. I also like to write a really nice summary to primary care so that they can help us. So I just writing in the chart, reviewing the IBD cornerstone checklist isn't helpful, right? Because our primary care colleagues might not know what that is or what our patient needs. So I spell out specific things. So I say 1, should have annual dermatology visit. 2, due for annual cervical pap smear if they're on infliximab or immune modulators, for example. 3, Hep B immune. So up to date, doesn't need it. 4, consider Prevnar. So I really make it clear, very clear in my notes so that patients and also primary care know what we need so that they can help us. Another question there, how long do you keep this steroid? Not more than 3 months, as little as possible. So if you get a good robust response, for example, on prednisone 40 milligrams, I would keep them on that 40 milligram dose for a week or 2 and then start to taper. I typically go by 10 milligrams until 20. So I go from 40 to 30 to 20 milligrams and then 5 milligrams a week after that. If a patient is very sick, they might need longer, but in general, we want them off as quickly as possible. Now, it also depends on what therapy you're starting, right? You don't want to taper them off the steroid before you've started their advanced therapy because their symptoms are going to come back and they're not going to have anything to keep them there. So really thinking about if you're starting a steroid, also starting advanced therapy at the same time, and thinking about the time of onset for that advanced therapy. So if in clinical trials for a drug, it took about 4 weeks for about half of patients to get a response, I'm keeping them on that steroid from a 20 to 40 milligram dose for that first 4 weeks before I taper further because I know they need time for that advanced therapy to get on board. So thinking about kind of can we taper quickly to 20 and then maybe a little bit slower, but how can we get patients off quickly and safely as possible with tapers? And for patients with complex disease features like perianal disease, extraintestinal manifestations, steroid dependence, prior biologic exposure, what are some of the most important evidence-based strategies for optimizing outcomes? It's really thinking about your individual patient. So for a patient who has extraintestinal manifestations, we want to think about, is this an extraintestinal manifestation that parallels disease activity or is separate from disease activity? So what do I mean by that? Peripheral arthropathies, for example, joint pains in the hands, usually parallel gut activity. So you don't need a drug specifically that's going to treat joint pain. If you heal the gut, those extraintestinal manifestations will probably go away. But if there's axial arthropathy, for example, that does not parallel disease activity. So you can have a completely healed gut and still have axial arthropathy. So you might think about a therapy that has a mechanism on joints as well. So maybe that's an anti-TNF or thinking about a JAK or IL-23s. When we think about extraintestinal manifestations, we want to know, does it parallel disease activity? Does it not? Is one of our drugs also going to treat it, in which case we could do 2 birds, 1 stone. So for example, someone with axial arthropathy or uveitis, that is not someone I probably would choose vedolizumab in as a first line because vedolizumab is gut selective and it's not going to treat uveitis or those axial arthropathies. So thinking about that when we think about positioning. Perianal disease is a beast of its own, and there are some guideline recommendations for perianal disease, but we got to kind of go strongly with perianal disease. I think often quality of life with perianal disease is underestimated for patients. Those who have steroid dependence, we also get them in with endocrine when we're thinking about tapering so that we can taper them safely. But also, are we really optimizing their underlying therapy, and why is it that they're steroid dependent? What inflammation are we not treating that only the steroid is treating? So really thinking about our patients as whole patients, using our guidelines as guides. I like to say guidelines are guides. They're not hard, fast rules. And sometimes our patients don't neatly fit into them. So using resources that you have, IBD is a team sport. So phoning a friend, getting another opinion from a colleague, if you have a physician champion in your practice. If you don't, is there another APP in the country that you could reach out to and ask some questions? What resources do you have? You're doing extra clinical education like this, so I know you want to take good care of your patients. So really thinking about all of the resources that are available to you for these really complex situations. And when needed, referring your patient to an IBD center for another opinion. Sometimes it really takes someone who is only doing IBD all day, every day, and really has this multidisciplinary team to get the best care for our patients. When treatment targets aren't fully achieved, how do you distinguish cause? So one, if there's new diarrhea, we've got to rule out infection, we've got to rule out C. diff, especially in our UC patients, but then also using all of our biomarkers. So is this inflammatory or is it not? And if it is inflammatory, is it a medication that we need to check a level on and make sure that we have appropriate drug on board, or is it not? If it is inflammatory, can we dose optimize? Or do we need to think about, did this patient not respond to this class of therapy? And do we need to think about another therapy option in them?
Thank you, Doctors Allegretti, Axelrad, and Cohen, and Nurse Practitioner Stewart. And many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Survey Says, Aligning Early Advanced IBD Therapy with Patient Priorities, please click the link in the show notes. And be sure to check back regularly for more episodes on important multi-specialty topics.